welcome back to the Big Ideas Theater at AARC Congress. I'm Ed Highland. I'm joined now by Rich Kallet. Rich, thank you so much for joining us once again.
Thanks for having me.
A couple of years in a row now talking about things.
Yeah.
So I want to talk this year about ventilator-associated events. First, a definition, if you would.
So definition of ventilator-associated event is a situation where someone has been on an artificial breathing machine for at least 2 days and is improving, getting better, or at least stable. And then after that their condition, their oxygenation begins to deteriorate, requiring the oxygen level to go up and the positive pressure we put to keep the lungs open to go up for a specific amount of time. So not just very quickly up and down, but sustained. So a patient is beginning to lose their lung function. So that's called a ventilator-associated condition. When that condition is tied to signs of infection, such as fever, white blood cell count, all these things going up a specific amount, and then antibiotics have to be started or new antibiotics added for a period of about 4 days. So this is something serious. That's what's known as an infection-related ventilator-associated complication. So these two things are considered a VAE, ventilator-associated event. The reason they came up with this is about 15 years ago, there's been a drive because of healthcare costs rising that we needed to cut down on hospital-related infections, medical complications, and there was a push to start benchmarking hospitals competitively, that they improve their care, and that insurance companies, the Center for Medicare and Medicaid Reimbursement, start saying we're not going to start compensating and paying for these complications. And then the Joint Commission for Accreditation of Hospitals kind of chimed in with that we're going to start making this part of hospital accreditation. So this is a very big thing. It was kind of taking the big stick out to improve care. Now, when benchmarking medical errors, things like a surgical site infection or operating on the wrong part of the body, or a fall that occurs in the hospital, or pressure ulcer, those are very easy things to benchmark. They're unambiguous. Pneumonia historically has always been kind of difficult to really nail down, and particularly ventilator-associated pneumonia, one that's associated with people being on an artificial breathing machine, is even more complicated. So this caused a huge problem. Some of the professional societies at the behest of the government put together a task force to try to come up with a more objective definition of these complications that they could start benchmarking hospitals more fairly. So what they came up with is VAE, ventilator-associated event, and what I just described, someone who appears to be doing better or stable and suddenly gets worse and it's sustained. And so they started with a nested thing, so a ventilator-associated condition, an infection-related associated complication, and then they could move on to diagnosing pneumonia. So the idea was they could nail down pneumonia. And so that's really, that's the background to why we have this.
And did this come out of some of the early studies that did not correlate very well with what you were actually seeing?
Well, when they first came out with this, so this is 2013, January, when the task force report came out. So immediately a lot of people who were involved in this, including Michael Klampus, who's speaking about an hour from now, is one of the world's experts on this.
We chatted with him as well here in the Big Ideas Theater. Yes, indeed.
Okay, so I hope I'm consistent with Michael's
saying. So far, so good.
But what they did is to go back and look at their data that they already had with a new definition and try to see how well does ventilator-associated events tie in with ventilator-associated pneumonia as it's been traditionally diagnosed. And also at this point, it's probably good to bring in, when we started talking about trying to decrease VAP, ventilator-associated pneumonia, they put together what's called a ventilator bundle. So things that we were doing, practices that we were doing that probably increased the chances of getting pneumonia. And so those were basically keeping the head of the bed up, not keeping people flat where they can regurgitate gastric secretions, aspirate them in the lungs and get pneumonia. Not having NG tubes, which drain the stomach in any longer because that makes it easier for the bacteria and the juices to get up. And the other thing was trying to get people off the ventilator and get their sedation down as quickly as possible. If you get the tube out of the throat, you get them off the ventilator, the chances of developing a complication go way down. Now, what happened in 2013 and 14, when they started looking at this retrospectively, they found that there really wasn't a good correlation between ventilator-associated events and ventilator-associated pneumonia. And the reason for that is two things. Number one is that ventilator-associated events is very objective. It's very strict. So before you can even begin to diagnose pneumonia, you have to move through these steps that are very clear to see. And so only about a third of pneumonia that we used to diagnose by the old-fashioned method correlated with ventilator-associated events. And the other part of it, which is also very important, is that a lot of patients never have a period of stability where they get better. So there are these patients that probably were getting pneumonia, but the new definition didn't pick them up. So that's not really all that surprising, but it kind of shifted, well, what are we going to do with this? And the other thing they found was interesting is that the bundle that they based treating VAP with, which its effectiveness was always somewhat questionable, and the data that the studies that was associated with wasn't that strong, but there was really no effect of the bundle. So in the past couple of years, to update you, basically they found the same thing, but there's some twist to it. So there still isn't a good association between ventilator-associated events and ventilator-associated pneumonia, and I think they've kind of given up on that. But what they found is that even though the bundle doesn't seem to be effective for treating VAE, or the incidence of it, there are elements of that that do improve patient outcomes. So Dr. Klompus, he might have even mentioned it, just published a study a few years ago on this from his institution, showing that specific elements do improve patient outcomes. So one of the things, again, with getting people off the ventilator sooner is what we call spontaneous breathing trials and daily sedation interruptions. So you try to challenge patients, can they breathe on their own, turn the ventilator off essentially, and let them breathe, see how they respond, and if they can go 2 hours breathing on their own without decompensating, chances are you take the tube out, the vast majority aren't going to need to go back on. If you can wean the sedation down, you challenge to see how much sedation they need, there's less chance of delirium, which is a complication. Their drive to breathe is better, they come off the ventilator sooner. We actually published last year, I might have mentioned it, that even in the most complicated disease to wean patients, which is acute respiratory distress syndrome, we showed that by doing these two practices, we decreased the duration of mechanical ventilation, ICU length of stay tremendously. So these are things that work. And so this has been repeated in the study that Dr. Klompus did and in others, that if essentially you run people at lighter sedation, you try to wean it down, you get them off the ventilator, it may not affect, it affects some aspects of VAE, doesn't necessarily affect the total bundle, but actually it's a good patient outcome. So we're not sure what we're going to do with VAEs in terms of benchmarking. It's been 5 years. There's really been no prospective study to give us solid evidence on this. But the things that we want to look at in terms of healthcare as a social concern is if we get people off the ventilator sooner, we don't sedate them as much or more than they need to, we get them off the ventilator and out of the intensive care unit and out of the hospital, complications will go down. So that's kind of where things are going with it. The one thing they did find is one of the things that we were doing with oral care, which is important, we were using a chemical called chlorhexidine. And there's been some studies, some of the studies I mentioned showed that, that in one case it actually increased ventilator-associated events, which is paradoxical, by about 40%. And the other one that there was a trend towards it might increase mortality in the hospital. And because it's a very kind of caustic, not caustic per se, but it's an antimicrobial substance that if it leaks into the lungs by accident over time, it may cause actual lung injury. So we still don't have solid data on any of this, but this is some of the new stuff, and the good news is that a lot of the things in the bundle, they may not affect VAE and pneumonia that much, but they do improve other outcomes.
Well, you've touched on it a little bit, but I wanted to ask very quickly, you caught us up to the present, so to speak. Yeah. What about the future, VAEs as a benchmark for performance, reimbursement?
Yeah, I think we're still even 5 years out because we don't have a prospective study that I'm aware of, and I just checked up before I came to do this, looking at PubMed, and I can't find any randomized controlled trials of the bundle. And we're probably not going to use, you probably can't randomize the bundle, not bundle, because elements of that do improve outcomes. But there's no solid evidence of that benchmarking VAEs is going to help. And if you start reducing reimbursement to hospitals on something that's shaky, that could actually have the paradoxical effect of hurting healthcare delivery, because hospitals aren't going to get the reimbursement that they need.
Let's hope that doesn't happen.
I hope it doesn't happen, but we're still a ways away. The good news, there's a lot of good news with this.
All right, well, Rich, thank you so much for sharing and updating us on VAEs.
Oh, thank you very much for having me.
This is the Big Ideas Theater at AARC Congress. I'm Ed Hyland. Thanks for joining us.